it's not the idea, and I don't want to convince you to use transcutaneous O2 measurement to replace blood gas analysis, but to include transcutaneous O2 measurement and the whole concept of dealing with neonates, critical ill neonates. So I don't want to go too much into details and principles of measurement with these techniques. I think we can discuss it, and we also can share some ideas what is different to other devices, but it's more the clinical use which I think is much more important. So indeed, some of this work is also done with the support of Sentec, but also with Accutronics. So to start this talk is, I think, very important. This was a survey done in Germany by the group of Mario Rüdiger and Roland Bauer survey. How many units, neonatal intensive care units, are using transcutaneous measurement, either CO2 or O2 alone or in combination. And what is interestingly, that 70% of all neonatal intensive care units are using transcutaneous measurement, and when you look, only around 50% are using CO2, either CO2 or O2 measurement alone. But let's go back. What is oxygen and what is oxygenation? And I think it's very important to know that it's a very complex system. And the complex system includes hemoglobin concentration, saturation, the content, the microcirculation, the macrocirculation, cardiac output, the function of the heart, oxygen delivery, and last but not least, delivery to the cell. I think it's very, very important to look at cellular level when we are talking about oxygen and oxygenation, and I think this is the most important thing. And for this, I think the microcirculation is the most important organ. We are always focusing on blood pressure, we are also focusing on cardiac function, but measuring the microcirculation, looking to the microcirculation is, I think, very, very important. And microcirculation, and everyone from you knows this very well, microcirculation is also independent of the gradient of the vessels, either the arterial side or the venous side. And this is, I think many of you know that this is a video microscope analysis of the skin of a preterm infant, and you see a huge number of vessels, you see the flow. You can imagine that this is a healthy microcirculation. And why I'm showing this is to show you and to share with you the idea that microcirculation in a healthy state is a homogeneous. And what you can see here is a healthy adult patient on a healthy volunteer with a sublingual microcirculation. But what you can see here is a typical septic patient. And this is a septic patient with an impaired microcirculation, and you see the impaired microcirculation due to the fact that you see here a heterogeneity of the microcirculation. You see areas which are very well perfused, but you are also observing areas where is no flow. And I think this is not only in the buccal mucosa or sublingual, this is also in the skin. And with this kind of technology, you can also observe and measure skin perfusion, but there are also disadvantages because this is not a established method in a clinical setting. It's really at this moment only a research tool, and it's also not really continuously method. But what is very important is that microcirculation, perfusion, skin perfusion, is also associated with worse outcome. And there are many studies, either in the adult field and now more and more of few studies in the neonatal field, that indeed microcirculation might be a marker of prediction of infection, but also prediction of worse outcome. And there are nice studies also done by Tibble, where improvement of microcirculation by giving fluids and or no improvement of microcirculation is also associated with a higher mortality. And I think for a neonatologist, it's very interesting to know what are really the targets and what are the limits of oxygen content, and I'm talking not here about saturation. And in the neonatal field, the content of 80 millimeter mercury might be a limit which might be associated with worse outcome. And in the neonatal field, 80 millimeter mercury was highly associated with severe retinopathy of the premature baby. So PaO2, measuring of PaO2 might help us also to guide patients. And there's also saturation targets, and I don't want to go so much into detail which saturation targets we have to use. There is an association with hypoxia and worse outcome in the neonates, and especially in the preterm infants. And we also know that resuscitation, newborns with room air reduce significantly mortality in this group. And this is also something which is observed in the adult field. A paper 5 years ago nicely showed that hypoxia is associated with worse survival. And recently, a few weeks ago, a very nice paper in JAMA also demonstrate in a randomized prospective trial, conservative versus conventional oxygen therapy, that the outcome was much better with a conservative target and conservative regime. And we all know from the neonatal field that even not only hyperoxia but also hypoxemia events are associated with a worse outcome, especially in neurodevelopmental outcome. And I'm showing these slides just to bring back into the mind that either hypoxia or hypoxia are associated with worse outcome. And very nicely shown that the ongoing discussion in the neonatal field between lower target or higher target, I think it's very important that special groups are benefit from higher target versus lower target. And here nicely the analysis also a few months ago published in JAMA, showing that especially the group of babies, the small of gestational age babies, which are more susceptible to oxygen, benefit from higher target compared to lower target. But I think this is not the real subject of this talk. I think it's very important to understand that adaptation is a process, and adaptation is also has something to do with physiology, and understanding physiology, I think, helps us to guide also patient or the treatment. And this is citate which I very like from Darwin: it's not the strongest or the most intelligent who will survive, but those who can best manage changes. And I think dealing with oxygen is a very good example that changes and dealing with changes helps to survive. And a very good example is the fetal neonatal transition. And everyone knows from you that intrauterine we have an hypoxic environment. I don't want to talk about fetal hypoxia because in a fetus it's a normal hypoxic environment. It's a normal, it's physiologically a physiological environment. And we know that CO2 levels in the fetus is very low, and this is also nicely comparable to Everest. That's why Barcroft mentioned the name Everest in utero. And I'm showing you these data and these slides because I think the transition is very important. And for the transition, it's very important not only have targets of saturation, but also deal in an individualized way, in a personalized way with oxygen. And I think in the future, this is a concept we have to focus on, and I will mention this also later. And interestingly, we were looking in our electronic charts, the first PaO2 at admission to the NICU, and this was done by one of our staffs, Dr. de Jonge, and he was looking and correcting also with FeO2 what is the first PaO2 on admission on the neonatal intensive care unit, more than 1,000 patients, divided them below 28 weeks of gestational age, 28, 23, 32, and above 32. And what he observed is that depending on gestational age, the first PaO2 at admission is lower in the smaller, in the babies below 28 weeks of gestational age compared to those above 32 weeks. And I think this is very important to understand that PaO2 levels from the fetal environment into the postnatal environment is also depending on gestational age, not only on GRU, intrauterine GRU, small for gestational age, but also on gestational age. And perhaps we have to adapt our treatments according to gestational age in the future. So hypoxia, and when we look into the nature, and everyone who are interested in high altitude research knows that in nature we have hypoxia, but there's no place in the world behalf our neonatal intensive care unit where we have an environment which is hyperoxic. And I think that's why hypoxia is caused by healthcare providers. It does not occur in nature, and evolution has not equipped the body to deal with it. And I think this is something we as neonatologists, our whole community, knows very well. Now more and more in the adult field, they realize that hyperoxia might be more harmful. So, and also, and this is a study we performed in the delivery room, is that measurement of saturation in the delivery room might be a problem also due to technical issues, but in our setting, we observed that the first signal you can achieve is after 2, 3, or 4 minutes. And it's also very important to know when you look to the targets, to reach the target in the delivery room, and I have to say that these are babies which are not delayed cord clamped, so perhaps the percentiles are different in those who are delayed cord clamped because of a better hemodynamic status. It's also very difficult to really be in between the lines, and this was also a study a PhD student from us, Tom Coase, was performing, and it was very difficult to be in between the limits we define. So just to continue a bit, it's also very important to manage oxygen in the delivery room. Perhaps in the future, transcutaneous measurement also will help us to guide the treatment in delivery room and to guide and support the transitional phase. So this is a setting, our setting, where we measuring oxygen saturation, where we measuring inspired oxygen, time of birth, cerebral oxygenation, and also tidal volumes in the delivery room. And also monitoring will help us, and this is what we were able to show, that in a study where we looked to advanced monitoring in a delivery room ICU setting on 15 babies, we were able to show by using advanced monitoring system that we are significantly less time above high SpO2 targets. But just by looking to percentiles, just by looking in a dynamic way to oxygen is, I think, very, very important. And this is, in our setting, this was an older study on our unit, how often we were able to be in between the target ranges 88 to 94, and most 30% of the time we were above 94, and nearly 20% below 88. This is what is well known, and that's why I think closed loop systems in the future will help us to better guide. And there are ongoing studies which are in outcome different, either showing a benefit or demonstrating no benefit. But we are talking about oxygen, and I was able to show you some slides in the beginning of the microcirculation. I think the skin is a very, very important organ in which we are able to look to perfusion, and also by looking to perfusion to look to oxygenation, and also to, oxygenation of the cells. This is the skin. Everyone knows how skin is present. We have capillaries, we have arteries, we have anastomosis. Remember the first films. And I don't want to go too much into the detail. This is a sensor which works with optical fluorescence excitation, and we can discuss it later on. What are the advantages? What are the disadvantages? But by measuring transcutaneous oxygen and also CO2, it's possible to get an impression about perfusion and also about oxygen. And as you all know, and this is perhaps one of the limitations why not so many people are using O2 measurements, it's important to warm up the place, the skin where you are going to measure it. And when I started with neonatology 20 years ago, this was something which was a very important issue, skin burns, and how often you have to calibrate the system. And this is also something where people say, okay, it's perhaps too difficult. What is the advantage and what is the disadvantages? And here a very old study showing that even microperfusion of impaired microperfusion might be measured by transcutaneous CO2 or also end-tidal CO2 measurements. And these are measurements without special warming up the sensor or the area where you measure. These are very old studies. When you are going into the literature, you really find old studies dealing with transcutaneous blood gas sampling. There is also very nice correlation between transcutaneous PO2 measurement and also cardiac index. These are only case reports, I know, but it gives you an impression that perhaps measurement of transcutaneous O2 is also helpful in managing in a hemodynamic unstable patient. And this is also very nicely shown in another patient which had a cardiac arrest during surgery, you really see before patient is, the condition is decreasing, transcutaneous PO2 measurement is decreasing as a sign of a worse perfusion. These are also very nice studies showing that only using saturation measurements, pulse oximeter saturation, gives not only a good picture about the PaO2 levels which are in the area you are measuring, and these are nice paper from Ben Stenson, who's also here, so if you have questions, ask him, not me, showing that either you are using higher targets or lower targets, you are not always in the PaO2 ranges you define, and you can argue and discuss what is the optimum PaO2 range where we want to treat the patient, but showing you that perhaps depending on gestational age, depending on intrauterine growth, it's important to define new ranges. And this, I think, is a very good statement of him, that it's another study which shows nicely that within the target ranges, SpO2 monitoring was associated with significantly more variable oxygenation than transcutaneous PO2 monitoring. I think this is a very interesting statement which support the idea perhaps to focus again more and more on transcutaneous O2 measurement just to improve outcome of our patients. So I want to summarize that oxygen is the most frequently used therapies in neonates. It's imperative to improve education in neonatal oxygenation and saturation monitoring. Changes in practices are necessary trying to avoid neonatal hyper and also hypoxemia, and transcutaneous blood gas monitoring could be recommended as a valuable complement for blood gas monitoring also in extremely low birth weight infants. Thank you very much for the attention.
Okay, so today I'm going to be speaking about the principles, the limitations, and then the clinical use of transcutaneous CO2 monitoring. I'm very excited to be here today and speak to you about this topic. Sentec has invited me to speak here today, and they've also provided me with the transcutaneous CO2 equipment for our study involving the very low birth weight population, which I refer to as VLBWs, under an unrestricted equipment use grant. So today I'm going to give you an introduction to transcutaneous CO2 monitoring. We'll then discuss the physiologic principles, the advantages and limitations, the clinical application, and lastly I'd like to speak to you about some current research underway in our unit. So let's start with a case presentation. We have a 23-week female delivered by emergent C-section for severe preeclampsia. Her birth weight is 600 grams. She's stabilized on a conventional ventilator following surfactant administration for respiratory distress syndrome, or RDS. An umbilical arterial catheter is obtained, and her blood gas on admission is 723 with a CO2 of 58 and a base deficit of -6. A subsequent blood gas is drawn 1 hour after admission, and we see 719, 63, and -8. 2 hours after admission, we have a 711, 83, and a -9. This is a pretty common kind of clinical case presentation in the NICU. As you can see, this patient is demonstrating a worsening metabolic and respiratory acidosis. Perhaps if continuous monitoring had been utilized versus this snapshot data that's provided through arterial blood gas sampling, we may have been able to notice a changing clinical picture sooner and respond quicker. So as this patient seen in our previous case and many other patients admitted to our NICUs, it's important to monitor oxygenation, the vital signs, and ventilation in these patients. So this is primarily done through pulse oximetry, cardiorespiratory monitoring, and historically frequent blood sampling. However, as alluded to in my case presentation, we do have the ability to do continuous monitoring through transcutaneous CO2 monitoring, and as Dr. Rice already spoke about, transcutaneous PO2 monitoring. This is done through a non-invasive technique, which measures skin surface partial pressure of CO2, which gives us an estimate of the arterial PO2. Here to the left, we have our Sentec digital monitoring system, which is SDM with V-sign sensor. This is just specific to transcutaneous CO2, whereas to the right, we have the monitor that's specific to both the transcutaneous CO2 and the transcutaneous O2. Again, I'm going to be focusing my portion of the discussion on the transcutaneous CO2. So why is this important? We know that severe changes in on CO2 levels affect our very low birth weight population in general, and they lead to alterations in cerebral blood flow. This is why this matters so much. This is particularly important in our preterm infants who are already at risk for having impaired autoregulation of cerebral blood flow. We know that an increase in CO2 leads to an increase in cerebral blood flow, and a decrease in CO2 leads to a decrease in cerebral blood flow. This predisposes our very low birth weight population to IVH and ischemia, respectively. This could also lead to potential long-term neurodevelopmental delay. So let's talk about principles. We did have a brief introduction to the sensor, of the PO2 combined sensor. This here is the PCO2 sensor. At the core is an embedded silver cylinder with heating elements and temperature reading ability. External to this, we have a thin electrolyte layer, and even more external to this is a thin membrane, which is permeable to CO2. So the CO2 then diffuses across the membrane and changes the pH in proportion to the amount of CO2 that is diffused. So the sensor is applied to the skin and heats the underlying tissue. Here we have capillary loops that extend from the subcutaneous layers up through the lower dermal layers, just under the skin surface. And the capillaries dilate in response to the increased temperature. This also causes an increase in cell metabolism and an increase in carbon dioxide production, both of which are stabilized and become less dependent on a change. So it works the same way as any other tissue. We're diffusing CO2, except in the skin it's unique that the CO2 diffuses to the ambient air. The living cells in the skin consume O2 and then produce carbon dioxide. So things that can alter our blood flow to the region can certainly alter our transcutaneous measurements. Things that improve our blood flow help the consistency of our transcutaneous measurements. So these things are increased temperature, increased cardiac output, improved hemodynamic status, and vasodilators. The opposite of all of these factors essentially decrease local blood flow to the area. So those include, again, decreased temperature, decreased cardiac output, a worsening hemodynamic status, or vasoconstrictors. So what methods can we utilize to best approximate PCO2? It's important to select a well-perfused measurement site. We want to make sure that the heating site or the heating of the sensor is allowed adequate time to heat before we obtain our measurement. We want to avoid mechanical pressure at the site. And we need to recognize clinical conditions in which we have altered hemodynamics. The ideal site is really guided by skin thickness and capillary density. So in a pediatric and adult patient, you can see for the PCO2 sensor, the ideal locations are subclavicular antecubital regions. Whereas in our neonates, or 1 month of age, we have the areas that are preferred are either on the clavicular region, the flanks, or also the inner thighs. So you can imagine that this is a much less challenging issue when we're talking about a term infant or a baby who's large for gestational age. There's plenty of space on this baby to find an adequately well-perfused site. However, for our very low birth weight population, this becomes quite challenging, especially when we're already limited for real estate and we have multiple other probes in place on these patients. transcutaneous CO2 monitoring allows for more timely intervention for patient care, especially in patients who are hemodynamically stable. So perhaps you see a rising transcutaneous CO2 measurement. This could possibly be alerting you to a blocked endotracheal tube, for example, at a time when suctioning may be sufficient. Or it could help us potentially detect air leaks sooner. Even in a patient who's hemodynamically unstable, though, we're still gaining some insight into their clinical status. So if you see a large discrepancy between PCO2 and transcutaneous CO2, this may be a tip-off that this patient is becoming septic or becoming less hemodynamically stable. And of course, this allows for fewer blood draws, which is important. So our hypothesis is that increasing inspiratory pressures and inspiratory times on NIMV will have a greater effect on ventilation compared to nasal CPAP, as determined by transcutaneous CO2 monitoring. So our first objective in order to validate our equipment was to determine the correlation between PaCO2 and transcutaneous CO2 in the very low birth weight population. These babies were required to have an umbilical arterial line in place at the time of the study. Our other objectives were to determine if incremental increases in inspiratory pressure and inspiratory time had an effect on transcutaneous CO2. Lastly, we compared nasal CPAP to NIMV head-to-head with regards to ventilation and transcutaneous CO2. So in summary from our research data, we can say that we found a positive correlation between transcutaneous CO2 and PCO2. Time-weighted transcutaneous CO2 does not vary significantly with changes in inspiratory time or pressure. Short-term use of NIMV is comparable to nasal CPAP with respect to ventilation and maintenance of cardiorespiratory stability. Conclusions for my talk today. I want to say that we have validated the use of transcutaneous CO2 monitoring in a new population of very low birth weight infants, less than 1,500 grams. Transcutaneous monitoring is valuable in identifying trends in hyper and hypoventilation, and we spoke about why that was important. And it has become a standard of care in our unit and basically on any ventilated patient in our unit. I'd like to thank Sentec and also Stony Brook Children's Hospital for the support for this study. Okay, thank you.